All right, anytime you're ready, you can start.
Okay, thank you. First of all, thank you guys so much for inviting me to do this. It's so sweet, and I'm happy to be here. For those of you who were here last week, I apologize that I had some connection issues at my end. We had a storm, but thank you again for being here today. I hope that you guys get a lot out of this presentation. And if not, at least you get a little bit of a framework for how to approach your applications for med school or whatever sort of pre-health activity you're interested in. So without further ado, I'll get started. So my name's Amina, and I'm a radiology resident in Long Island. I'm a senior, so I'm going to be graduating next summer, and I just passed my boards. So that part of my residency is over. I matched into fellowship. So I feel like I have a lot of perspective that I can bring to this conversation, not just about radiology, but also about just the general path through medicine, how long it takes, the level of commitment, and just, sort of a lot of different questions that you guys might have about the more general aspect of becoming a doctor. Hopefully I can answer those along the way as well. Okay, so I just listed a couple of ways that you guys can contact me on social media. I'll repost these at the end, so don't worry about taking it down if you don't want to right now, because I'll post this again. So let's get started. I kind of already went through this, but I'm originally from Atlanta, Georgia. I went to the University of Georgia, double majored there in biology and ecology, then stayed on at our state med school, the Medical College of Georgia, for med school, did my internship in Atlanta at Morehouse, and now I'm doing my residency at Stony Brook in Long Island. So as you can see, it has been over a decade since I sort of started my this whole journey, and it still hasn't ended. So it's a long time, and it's quite a bit of commitment, but if you're willing to do it and willing to put forth that effort, then I do think it's worth it. So let's go to the next one. Okay, so as I mentioned to you guys, I did my residency in radiology, and I matched into my fellowship in interventional radiology at NYU. So I'm going to be starting that next summer. These are the rest of my the cohort of people I'll be working with. I'm super excited to be doing my last bit of training at NYU. It's one of the best places to get medical training and treatment in the world. So I'm really looking forward to that experience. And, if you guys have any questions about their program, their med school, please reach out to me as well. So a little bit about my family. This is my family on my wedding. And this is my husband, my mom, my dad, and all my siblings. And the reason why I'm bringing this up is not to bore you guys or tell you too much personal information, but it's really because my immediate family shaped so much of my experience and my journey into medicine. Starting with my older sister here, she is the reason that we actually moved to America, because my family is originally from Pakistan, and my sister needed a heart transplant. And so when I was like less than a year old, we moved here, and she had heart surgery by the father of modern heart transplant surgery, Dr. Norman Shumway. And if you guys Google him, you'll see that he he's the first person, the first surgeon to perform a modern day heart transplant. And my sister was one of the last people who he operated on. So it started with her. And then my mom, when I was in high school, had breast cancer, and she had a bone marrow transplant. And several years later, when I started residency, my older sister again had to have a liver transplant because of an autoimmune issue. So basically, over my entire lifespan till now, we've had 3 transplants in our immediate family. We've moved across continents to experience the life-saving treatments and technology of American medicine. 2 lives have been saved, but countless lives have been changed because so much of what I witnessed growing up inspired me to go into medicine and to make a difference in people's lives. And not only myself, but my brother's in med school, my sister is in dental school, and my younger sister is an aspiring physician as well. So lots and lots of lives were changed by these experiences, which weren't always easy. So I want to just challenge you guys to not be so afraid of the difficult experiences, the challenging experiences in your life, because sometimes they are the catalyst for what's going to change the trajectory of your entire life. So don't be afraid to dig back even to memories that were sometimes, not the best, things that you don't want to relive or rethink about, because in there you find your wisdom, you find your truth, and it's going to guide you through life, even through the most challenging moments, or even through over a decade worth of training and learning, like it did for me. So let's move on to talking a little bit about different subspecialties. So I found this chart basically as a medical student did a study about the stereotypes of different medical specialties. And so the bigger the word under each specialty, the more common it was to classify, or the more commonly it was used to classify that subspecialty. So for example, pediatricians were commonly classified as kind, fun, friendly, childish. Cardiologists were commonly classified as intelligent, clever, serious, smart, intense. And I'm going to just point you over to radiologists, who were characterized as dark, visual, boring, quiet, reclusive, lonely. And I challenge these stereotypes because when I was in medical school, these were just so commonly touted, and everyone would say, "Oh, you're going into that specialty, Amina. You don't belong there. You're not quiet. You're an extrovert. You need to go into something else." And the truth is that you can be all of these. You can be none of these. You can be some of these some of the time. You can be some of the other ones some of the time. You have to do what speaks to you. And maybe it's everything. And maybe it's going to take you some time to figure out exactly what you want to do in medicine. But I do challenge you guys to not fall into this trap that you have to fit a certain mold, a certain personality to become a part of a specialty. And, I've come into radiology, and so many people have asked me, "Hey, I want you to help promote the field. I want you to help speak to medical students, to pre-meds, because you have this ability to engage with an audience." And so you don't have to fit into one of these categories. You can be different and still do any of these fields that speak to you. And that's the message of this slide. And with that said, we're going to jump right into radiology, because I feel like nobody knows what radiology is at your level. And even when they get to medical school, and even doctors who I interact with now, sometimes they don't know the full extent of what we do. And so I divided our subspecialties within radiology into those that have intervention and still have a lot of patient-physician interaction. And these are all the specialties on the left here: breast radiology, interventional, musculoskeletal, nuclear medicine. And then those subspecialties that are a little bit more focused on diagnostic imaging. So reading studies and making diagnoses. So we have pediatric radiology, if you're interested in children's imaging, neuroradiology, body imaging, chest, and emergency radiology, if you like the faster pace of medicine. And so moving on into this sort of realm, as radiologists, we use this word very commonly, modality. Okay. And a lot of people outside of radiology have no idea what we're talking about when we say modality. They're like, what's that? But it's the crux of everything we do. The modality is basically what are we using to get the images that we're interpreting? And it can be done in a variety of ways. So if you use one-dimensional X-rays, that's called radiography. So that's your traditional chest X-ray, your traditional, X-ray of the arm, X-ray of the skull, X-ray of any of your extremities, abdominal X-rays. So it's a one-dimensional X-ray. Once you go to three-dimensional X-rays, it's called a CT scan. When we use magnets and we do three-dimensional imaging, it's called an MRI. When we use X-rays to actually do image-guided interventions, it's interventional radiology. When we use radionuclides to image, that's nuclear medicine or radionuclide imaging. And when we use ultrasound waves to generate images, that's called ultrasound or sonography. So the modality is really how are we getting the images, and it dictates how we're going to interpret them. So it's really the bottom line of everything that we do as radiologists. And even if you don't become a radiologist, it's important to be familiar with this because you're going to be ordering the studies for your patients. So you have to know if it's a child, do I really want them to get a lot of radiation? So I can use an ultrasound and still get the answer that I need. So this is all important information for you, even if you don't go into radiology. So what do we do once, as a radiologist, I go to work every day, right? And someone puts an image in front of me. What do I do? How do I even start? And that's a difficult thing for anybody, even when you're starting out training, but especially if you have no exposure to radiology. So I'm just going to give you guys a general overview of how to approach an image, and then take that with a grain of salt because it's modified slightly for every different modality that we use. So the first thing that we do is figure out what modality. Am I looking at an MRI, a CT, an X-ray, an ultrasound? That's the first question you need to answer for yourself. The second is, how was this image acquired? Okay, so in the hospital setting, you have patients who are very sick, right? They're in the ICU. They can't walk down to the radiology department and get their images. So in those cases, we do what's called portable exams. And these actually affect the way that we interpret the images. Because if you think about it, if you take a picture while a patient's laying down sick in bed, it's going to limit your evaluation of that image compared to a person who's sitting up and able to follow directions in order for you to get that image. So that's important. The next thing is history. Why are we getting this imaging done? What did the patient present with? Were they a trauma patient? Were they sick? Did they have a fever? Do they have a history of cancer? All of these things come into play when we're looking at the images, because sometimes you'll have a finding and it could just be negative, but if you have a medical or clinical context, then it could become more concerning. And then the next thing is a search pattern, which I'm going to talk to you guys more when we do some cases, and then pertinent positives and negatives, which I'm going to tell you a little bit about in a couple of slides. So if you guys have taken anatomy, you might be familiar with the concept of imaging planes or just anatomical planes in general, okay? So anatomic planes become very important in radiology because when we look at an organ, when we look at the heart, when we look at the lungs, when we look at the liver, the spleen, we want to be able to look at it not just in one plane. We want to be able to look at it in multiple dimensions so we can three-dimensionally recreate the body and make sure that we're not missing anything when we're reading the scan. So the coronal plane is if you just imagine the patient in front of you and you're taking images as you slice them from front all the way to their back, okay? And then the sagittal plane is just if you take the patient in front of you and you're just slicing them side to side, okay? And the axial plane is if you're slicing them starting from the head all the way to the feet. And these are the three anatomic planes. We obviously are referring to them as imaging planes here, but we use these for every single modality. And it's going to be important. We'll talk a little bit more about this with the cases as well. So finally, before we move into the funner part of this discussion, I want to give you guys an example of descriptors, okay? So as radiologists, we're looking at all of the organ systems, right? And when we communicate with other doctors and other physicians, we want to be able to communicate in a standardized way, but that tells them not only what we're looking at, but if it's normal, if it's abnormal, how abnormal is it? And so that's what this is an example of, okay? So here we're describing the heart. This is the anatomic location, and we're saying it's abnormal, right? It's enlarged. An enlarged heart is an abnormal finding. So how enlarged? Is it mildly enlarged, moderately, grossly, severely enlarged? And so that's why you use these descriptors. And here's another example. There's minor blunting to the left claustrophrenic angle. So here again, we're talking about the anatomic location, the claustrophrenic angle. We're talking about the finding, blunting, and we're giving you a degree of severity so they know, is this something to worry about, or is this something that, you know, is probably just an anatomic variant? And then pertinent positives and negatives. I mentioned that in the slide about approaching an image. So here's a pertinent negative, right? If we're looking at a chest x-ray, we obviously want to tell them if there's anything in the lung. And if it's negative, we don't just want to not write anything. We need to write no active lung lesion, so they know there's nothing there. Because if you leave it out completely, people are going to ask, did you actually look at this? All those sorts of things. So we want to avoid that. All right, so the next part of this presentation is my favorite part, because radiology is really all about looking at cases. And I could talk to you guys all day about how to approach an image, physics, and all of these really complicated anatomic terms. But you really get into it and you really start to get excited about it when you see the cases and you see all of the different things that we can do. So that's what we're going to do. This part is a little bit interactive if you guys want it to be. So I'm just going to invite everybody to write in the chat box if you're interested, and I'll just try to keep an eye on that. So without further ado, let's get started. So this is the first practice case, and I just want you guys to start by telling me what the modality is. Okay, you can type it in the chat box, you can unmute yourself, whatever works. So let's see. Yes, X-ray, excellent. Zara, very good. Okay, and then what is the plane? So remember, we talked about the planes. We said we can get coronal, you can get sagittal, you can get axial. Someone wants to type in what they think the imaging plane is here. About 10 seconds for this. Once. Coronal, excellent, very good. Okay, so good. And I'm just going to tell you guys, this is a normal x-ray, okay? There is no abnormal finding. This right here, this sort of dark structure that goes down and then branches out like a Y, that's your trachea, okay? And that looks normal. These are your lung fields. I don't see any large opacity. This is the heart here. It looks pretty normal in size. Then I start looking at the bones, your clavicles, your scapula, all of your ribs look fine. You want to look at the base of the diaphragm, your spine, and then just look at any soft tissues to look for any abnormalities there. And this is a crystal clear, absolutely normal chest x-ray, okay? But it's great that you guys are going through the process, which is modality, plane, findings, and this was the part where I was talking about the search pattern, right? Everyone's is going to be slightly different, but for me, I always start by looking at the airway, then I look at the lungs, then I look at the heart, then I look at the bones, then I look beneath the diaphragm, and then I look at the soft tissues. Every single chest x-ray, every single time, just so I don't miss anything. And it's going to be different for every modality, as we'll see. All right, so this is our next case. So I have our 4 questions here. So this is clearly an abnormal chest x-ray. If you guys want to type your answers in, as far as what modality, what imaging plane, how would you describe the finding that's outlined by the arrows? And what would you think might be the history in this patient? Give you guys a couple of seconds. Okay, all right, well, we're gonna move on because I don't see anything in the chat, but I'm assuming that you guys, this one is, it's a little tricky, but I think you guys will get it once I tell you. So again, this is still a chest x-ray, right? And this is still a coronal, or we sometimes call it a frontal imaging plane. And here we've got a nice consolidation in the right middle lobe. And the expected history in this case would be someone with a fever and chills, right? Because you're concerned about a pneumonia, right? When you see sort of this opacity, this dense consolidation in a very well demarcated part of the lung, the first thing you should think about is a pneumonia. Yes, could it be other things? Could it be a cancer? Could it be a mass? It could be, but most commonly, and you'll hear this phrase used a lot in medical school, when you hear hoofbeats, you should think of horses, right? And not zebras. So that's the first thing you should think of. Of course, if you get other history, like this patient does have a history of cancer, then you might go down a different route. But common things being common, you would want to think of pneumonia first, okay? All right, so let's move on to a next practice case. So this is a CT scan, all right? And that's a modality. Remember, 3-dimensional X-ray is a CT. And we have our imaging plane. This is a coronal, right? So we're looking literally as if we're looking straight at the patient. And we have some normal anatomy, which I'm just going to guide you guys through. So this is the base of the heart. Here are the lungs. Here's the liver. This is the portal vein, the gallbladder. We've got part of the stomach, part of the spleen. We've got your small bowel here. Here's your small bowel mesentery and your mesenteric vessels. Here's your cecum, your bladder, your sigmoid colon, and then we've got your pelvic bones and your femurs here. So there's a lot of anatomy. And, you know, when you're first starting out, it can be very daunting, right? Because you're not just learning the anatomy on a CT, you're learning an anatomy on an X-ray, on an ultrasound, CT, a mammo. So I just, I'm showing this to you guys as an exposure of all the things that we do. Obviously, you don't have to learn all of this in medical school. It's just for you to know that this is what people are looking at when you order a CT scan. So this is a normal CT. I don't see any issues or abnormal findings here. So I've got another case for you guys, and let's see if you guys take a crack at it. So remember, this is interactive. So go ahead and type in the chat box what you think the modality is, the imaging plane, how would you describe the finding here, and what do you think the history might be? And this is a tough case. So if it's totally fine. But if you can answer at least one or two of the questions, I think that would be great. At least the modality, which I think is, given away on this slide. Let's see here. In the chats. CT, coronal, the left lobe is grossly enlarged. Yes, so absolutely. Yep, the CT, this is a CT, this is a coronal. So interesting that you bring up that this is the left lobe. And I think that's a very common, so someone said possible mass. So one thing I want to just talk to you guys about. So when we look at images, everything is flipped backwards, which makes it extra complicated. So, normally you're looking at this and you're like, this is left, right? And this is right. No. So the way that we acquire the images is done in a slightly complicated way that I don't want to really go into right now, but essentially everything's flipped. So left is right and right is left. Okay. So this is actually the right lobe of the liver, and it is enlarged. And there is a mass here. Okay. There's a huge mass here. Remember, looking back at this liver, look at how homogeneous that looks, right? There's nothing in there that doesn't have the same texture as the rest of the liver. It all looks pretty much the same. Here you've got this huge enhancing mass here within the liver on a coronal CT. And I will just tell you guys that this was an asymptomatic patient. He was a young patient, and the diagnosis ended up being a liver hemangioma, which can sometimes get this big in very young people. And it can look very scary. It can look very concerning. But as radiologists, we're trained to diagnose this because we know what the imaging features look like. We know what are the most common locations. We can get an MRI and confirm it based on the enhancement pattern. So there's a lot of things that we can do without having to go in and actually put a needle in there and biopsy it. So great job with everyone that answered that case. All right, so moving on to our next modality. I've given that away here. This is just a normal ultrasound, okay? So this is a sagittal ultrasound of the pelvis. This is a female. This is her uterus right here. This is a vaginal canal, and the bladder is sitting in front of the uterus, normal anatomy, okay? So I'll just tell you, ultrasound is one of the most complicated modalities, in my opinion. And I think that even for very seasoned radiologists, it can be tough sometimes to figure out exactly what's going on, especially when there's an abnormality. So it sounds like it's easy, but it can be very tough. So don't feel frustrated if you're like, what is she seeing? I can't tell what that is. So here's another case. This is also an ultrasound. So if anybody wants to take a crack at what the imaging plane is, I'll give you a hint. I've already shown you this imaging plane, and just take a guess at what the history might be of this patient. There's some hints in the over here. All right, let's see what we've got. Okay, and I am going ultrasound axial, a possible mass. Sarah, very good. Yes, this is an ultrasound. This is actually a sagittal, and there is a mass in here. I'm just going to compare it. So I want you guys to look at this, right? You see, this is the uterus, okay? See how you're kind of seeing, I'm outlining it from the side. Compare it to here, right? It's kind of similar. It's a little complicated, but you're looking at it from the side. So this would be a sagittal image. And very good. Excellent, Zara. So yes, this is a pregnant patient, and 1 second. All right, great. Yep, so this was an ultrasound sagittal plane. And what you see is in the uterus, you've got a tiny little fetal pole and a yolk sac that's just attached right there into the lining of the uterus. And the expected history would be a missed period with this, right? So this is a very, very early sign of pregnancy. And very, very common. I think I would say I see this about, a couple of times a week. Pretty much every time I'm on call, there's pregnant patients. We see pregnancy complications. We see people who are coming in with cramping who just want to check on the baby. So this is something that radiologists see a lot on their day-to-day. And by the way, guys, I'm going to answer your questions once we get to the end of the presentation. I'm not ignoring them. I'm definitely going to get to them as we get closer to the end. Okay, so I'm just going to go through this case because it's a little bit of a unique modality that even a lot of other doctors struggle with. So I'm not going to quiz you guys on this, but this is a normal mammogram. So as you guys know, breast cancer is becoming more and more prevalent. And unfortunately, that over time, we're seeing more and more aggressive cases in younger women. So there's been a push to get screened earlier in life so that we can detect and catch breast cancers at a younger age, treat them, and then give women more years of life. So one of the ways that we screen women is through mammograms, and a mammogram is basically an X-ray of the breast, okay? And it looks different from a traditional X-ray, like the traditional chest X-ray that we looked at, but essentially you're looking at the breast from the side. Here's the nipple, here's the pectoralis muscle in the middle, and this is an essentially normal mammogram of the breast. I don't see, this is just some normal glandular tissue behind the nipple and no issues here, okay? So this is, again, another mammogram, and we've got a spiculated mass in the lower quadrant of the left breast, and there was a family history of breast cancer here, and so the diagnosis here was this turned out to be a breast cancer. There are many different types of breast cancer. Radiologists and pathologists and oncologists deal with different treatments. We have invasive ductal, you have a lesser aggressive form of breast cancer, DCIS. So it becomes very, very complex, but this is just a very, very basic introduction, just so you guys have seen it and heard about it before. All right, so that's all I have for you guys with cases. And I just wanted to give a quick summary about radiologists. This may or may not be your first time ever hearing from somebody in the field. So really the way I think about what I do is that we are almost like physician detectives, right? So we're basically, when a doctor looks at a patient and they are not sure exactly what's going on, we get these imaging studies and we're able to take clues from the imaging studies and narrow down the diagnoses. And I think that really helps our patients and helps the physicians. It saves them so much time, because if you really think about it, 100 years ago, we could not see inside the human body until after the patient was dead, or during an autopsy, right? And now fast forward to the 21st century, and we can in 5 minutes do a scan and see what's going on inside the body, whether the patient has cancer, or whether or not they have a pneumonia, or what's the source of their clinical presentation. So it's really, really pretty amazing, all the things that we can do. And I think that we play a critical role when we're talking about surgical patients, preoperative screening, post-operative complications. I told you guys a lot about the transplant history in my family. We deal a lot with transplant patients as well. And I think that, radiology is one of the most challenging specialties in medicine because we have to look at such a wide spectrum of pathology. We have to know so much about all of the imaging modalities. We have to keep up with all of the different treatments, all the different surgical innovations. So it's an ever evolving field. And if you want to do something in your life that's cool and intriguing and that's going to constantly keep you on your toes, I highly encourage you guys to think about this in your future career. Okay. And so this is just, again, my social media. If you guys want to reach out to me, please feel free to do so. I'm happy to talk to you guys offline. I will caution you guys though, sometimes people's messages, they go into, especially on Instagram, I've noticed, into a box that doesn't come directly to me. So it takes me a few to respond to you. Please don't be alarmed. I will eventually get to it. Okay. And this is sort of key. Okay. I'm guessing that most of you guys here are pre-meds or interested in some, pre-health route. And I was very, very shy at your stage, extremely shy and introverted. It might seem hard to believe right now after I just gave you like such a long presentation and, I sound very confident, but I wasn't always that way. It took me a while to get to this point. And what I wish I had known earlier was the importance of networking. And when I was at your age, I kind of thought networking was like this very sleazy thing that people did and, just kind of reach out to people and, just it very unauthentic. And I want to say that it can seem that way sometimes, but I think if you're persistent and you do it with a very, in a very genuine manner, then I don't think there's anything wrong with it. And I think it can only help you because the more people that you connect with, it's not just if that one person is going to help you. It's what you learn from talking to them. It's what you learn from listening to them. So what you're doing here, everyone who's here today, you're already like far beyond everyone else who is trying to do the same thing because you are listening and trying to get other people's advice and insight. And everyone is going to have different pieces of advice for you, right? Networking isn't necessarily about climbing into someone's DMs and just being like, hey, like, can you help, connect me? It's really casting the biggest net and getting as much advice and soaking in as much insight as you can about the process, about different people's journey, because it's going to give you insight into your journey, into how you can propel yourself into a similar trajectory and into a similar path. Okay. So that's really what I mean by networking. And I encourage you to keep doing this type of thing, keep reaching out to people because it's only going to benefit you. Okay. And then the last thing that I'll leave you guys with is this. You're going to have a lot of people who doubt you. As I mentioned at the beginning of this presentation, I have been doing this now for over a decade. I've, from undergrad to medical school, radiology is one of the longest residencies. I've come across a lot of people who have doubted my abilities, doubted my skills, doubted my intelligence. And I can tell you that at the end of the day, the best thing you can do is prove those people wrong. And the way you do that is by having unwavering belief in yourself. Okay. Unwavering confidence, no matter how hard it gets, that you can do this. And I think that comes by surrounding yourself with supportive people, your family, your friends, your significant others. Um, you know, I think it's hard to believe when you're in high school or, even at that stage that the people in your life now may not be there in like 5 or 10 years. But it's true. You're going to make different friends. You're going to have different people. And I think that that's important to realize that you get to choose the people you surround yourself with and surround yourself by people who believe in you, have faith in you, and encourage you because it's a long road. And when I look back, I know that some of it was me, but a lot of it was the people who supported me and encouraged me. So I want you guys to find that for yourself as well. Okay. And with that said, that's all I have for you guys. Thank you so much for your attention and for being here on a Sunday evening. I know that's not easy. So I will take any extra questions that you guys have. And I see some coming up in the chat box. So if it's okay with you guys, I'm just gonna start answering them. Is that okay?
Yeah, go ahead.
Okay, awesome. All right, so let's see. So these were, from the cases earlier. So Amanda asked, it's according to the patient's left and right, not ours. Yes, Amanda, that's correct. It's the patient's left and right, not ours. So when you're looking at images, right, like when I said it was flipped, right, when you look at the screen, right, it's left is right, right is left. It's because you're looking at the patient. So that's what that's in reference to. And then, let's see, Amanda asked, the yolk sac isn't present till about like 6 weeks pregnant. It presents later. It's slightly variable. I'm not sure about the exact, there are some like cutoffs for people who, could be a little bit earlier than that. I'm not an OBGYN, so I don't want to tell you definitively, but it's not an immediate thing. Like the HCG starts rising and then, a lot of stuff has to happen, yes, before we can sonographically detect the pregnancy. So Michelle, what do you think are the greatest challenges while completing med school and then residency? That's a good question. So greatest challenges. It's a lot. And I think everybody would answer that question kind of differently. For me, I felt like relationships were very hard because your time just gets sucked away into all of these things that you have to do for school and, for being in the wards and in the hospital. And, it can just, a lot of times your friends, your family, they're going to go out, they're going to have events and you just won't be able to make it because you're on call or, you're working nights. But that's why I emphasize like surround yourself with people who encourage you and understand because that's going to make all the difference, right? You're going to have friends who are going to be like, oh my gosh, I don't understand why she's never available. And then you're going to have friends who are like, she's doing something awesome with her life. So, have at it. So I think that's kind of this was the struggle for me. How often are you seeing patients during a typical day at work? Can you share what a typical day for you is like? Sure. So as a radiologist, because I'm going into interventional radiology, I see patients all day. We do procedures all day and sometimes at night as well with trauma patients. And then when I'm doing diagnostic radiology, it can be hit or miss. Sometimes you do have to go see a patient, tell them about a critical finding. A lot of times you're having discussions with other doctors about the findings on patients and discussions with them. So it's a little variable depending on what rotation I'm on. But right now I'm on interventional radiology, so I do see patients pretty much all day. And a typical day for me on an interventional radiology is I get to the hospital at 6 in the morning, and I just start reviewing all the cases for the day. I check to make sure like we have everything, all the materials that we need for our procedures. What rooms are we going to be doing? I look at which attendings are scrubbing which case. I review all of the images, and then we just go. So usually we do one case an hour. If we're in a big case, like a cancer treatment case, sometimes those can go on for 3 or 4 hours. But yeah, and then usually the day ends by like 6:30. I come home, and then I turn off everything that happened at work and just focus on my family life. So that would be my typical day. Okay. So Brianna, thank you. What would you say helped you prepare for the application process for med school? Any tips you would share about being pre-med in college? Okay. So for medical school, let me see. I guess these are two questions. All right. So tips for being pre-med in college. Basically try to do well in all of your prerequisite classes. And then outside of prerequisite classes, take classes that you enjoy. I took a ballroom dancing class. I took a voice class where I learned how to sing. I took let's see, I was really into like history. I took sociology, anthropology classes. And it was nice because those classes were a little easier. So then it made it like that I could really focus on doing well in like the harder classes like organic chemistry, biochemistry and all of those things. So my advice is to kind of make sure you do really well on your prereqs, and then the other classes you should just totally have fun in and not worry so much. And then preparing for the application process for med school. So the way that I think about application process for med school is it's a formula, okay? It's very, very formulaic. You have to take your MCAT, right? You have to take your prerequisites. You have to do well. You've got to write your personal statement. Your personal statement should not just rehash your CV. It should talk about you as a person. Who are you? What will you bring to the table? What will you bring to the medical school? And then, and basically, then the application, right? So, and then your letters. So it's really like a formula. Once you start to just like check off the pieces of the formula, you should be good. And then have people look at things like your personal statement, have people look at your application, make sure there's no typos, no errors. You don't want to give people a reason to think like, oh my gosh, I don't pay attention to detail, because really being a doctor is all about paying attention to detail. Okay. So, and then Zara said, thank you so much. This is more of a fun question, but do you find that radiologists are properly portrayed on medical dramas? I actually, it's so funny. I did watch Grey's Anatomy for like a little bit. And I watched Scrubs. That was actually my favorite show, but outside of that, I haven't really kept up with watching medical dramas, mostly because I feel like I'm in one. In med school and in residency, it's just a lot of drama you'll see. But I actually don't know. I've never looked at them from that angle. I don't know. Type in how you think they're portrayed. I mean, there's definitely, I would feel like I'm an outlier for most radiologists. I'm definitely have a part of me that's a little bit more extroverted and more, just like bubbly and willing to talk to people. A lot of radiologists kind of aren't like that. So, but again, like I said, you don't have to fit the mold. You don't have to fit the box. So I would say that's a funny question, but maybe I'll check out some more recent dramas and try to find an answer to that for future things like these. All right. So Amanda, Did you complete any other titles or jobs during undergrad, or did you just go straight through? I'm a human bio major, debating between med or PA school, but I'm in school to be a MA in the meantime. Okay, I'm not sure what an MA is. I'm assuming master's. Okay, so as far as me, during undergrad, I went straight through. I did have some jobs when I was in high school. Oh, medical assistant. Okay. Um, so when I was in undergrad, I was like a tutor, and I also was like a resident assistant. It really had nothing to do with going to med school. I just did stuff that I was good at and could get paid for. So um, I would say that um, you know, it's fine. I mean, if you're doing a medical assistant job, I think that's great. And I think that that's going to help you definitely a lot in med school. I wish I had the foresight at that time to do something like that, but I didn't have a car and I had a lot of other issues like with transportation that made something like that a little harder. But, you know, I think if you can do it, I think that's great. And I don't think that it's going to hurt you at all, whatever pathway you choose, med or PA school. All right. So have you ever faced any challenges as a woman in medicine? Also, did you always want to pursue radiology, or did you have an aha moment in med school? That is a fantastic question. Okay. So yes, I face challenges as a woman in medicine every single day. I think that um, you know, it's just, it's such a hard question to answer too. On one hand, it's easy because the answer is yes. But on the other hand, it's hard because there's just so many small ways in which it's challenging and it accrues over time. You know, for example, you're never, at least I am never assumed to be the doctor ever. If I'm in a room full of other men, it's never assumed that I'm the doctor. It's always the nurse or the tech or someone else. And you know, it's people from the industry coming in and, you know, not referring to you as a doctor. But I think like over time, I've kind of learned how to deal with these things with a little bit of a sense of humor because you don't want to offend people or make them feel bad because sometimes people just, they do it because they don't realize or, you know, they think it's, they really do think, oh, you look so young. And it's not necessarily because they're questioning your competence. So, you know, I always laugh and say, oh, do I look really young to you? Or like, you know, oh, thank you for making me feel so beautiful or something like that, just to kind of, you know, bring a sense of humor, but also, you know, then reality is that, yes, but I'm your physician today and let's talk business, you know, so people know that you do have the competence and the knowledge to help them just like your male colleagues do. So that's what I would leave you guys with. I think we're far from a place in time where I will tell you all that you're never going to face challenges in medicine as a female. But I will tell you that the ways that you can deal with it are with a little bit of sense of humor and then redirection, right? So when you're faced with this, don't just make people feel bad and go home and make yourself feel bad, but learn to kind of laugh and then redirect. That's at least what my philosophy is. So, and then the next question was pursuing radiology. Okay, so this is also another great question. So I did not know what I wanted to do when I went to med school as far as specialty goes. I was just very open. I'm like, oh my gosh, I'll do this, I'll do that. Even towards the very end, I was just debating on what I would apply to. And I ended up really liking radiology because it has a little bit of everything, right? It's got the pediatrics, it's got the emergency, it's got the patients, it's got the procedures, it's got all of the age ranges. But then it also sometimes, you know, in med school, you feel like you forget all of the things that you've learned early on, like anatomy and physiology and all of these things that I kind of felt like I was pretty good at. And I was like, I don't want to lose it, you know, going into a field where, you know, I might just be talking to people or not really using that knowledge and skills. And I feel like radiology really kept that because you use your physics, you use your anatomy, you use your physiology, you use your clinical knowledge every single day. So that was really kind of what prompted me and pushed me towards that field. So and don't be intimidated by the physics. I mention it, and I know that everyone kind of freaks out. They're like, oh my gosh, I can't do physics. It's not that bad. It sounds worse than it actually is. I think physics in college is actually harder than the medical physics that you need to know to become a radiologist. So don't freak out. I know I questioned myself. I'm like, I'm not that good at physics. Should I be a radiologist? And then someone told me, no, just push that thought aside. There's very little that you have to know to become a competent radiologist. So I don't see any more questions in the chat. So I'm gonna hopefully assume that I answered everything. I think I did. So guys, again, feel free to reach out anytime. You know, I'm available, and here I'll just if anybody needs to screenshot this, they can, just to get my contact info. Okay. And thank you guys again.
Oh, sorry. Thank you so much for rescheduling with us. And I really loved your PowerPoint and just everything that you had to say. So.
Oh, thank you. It was a pleasure to be here. You guys are doing great things. And trust me, like just being here on a Sunday evening speaks volumes. Okay. Volumes. So have faith in yourselves. You guys are all going to do great things. And remember what I said about you finding those people that are going to be the encouragers in your life and never giving up on yourself throughout the journey. Okay.
Okay.
All right.
So much.
Good luck, guys. Take care.
Bye-bye.